most were in rural areas and have served their communities for decades. You own a small group of rural pharmacies and recently had to close some. What legislation would you like to see Congress pass to help rural pharmacists like yourself and the patients you serve? And since bureaucracy can work faster than Congress, is there anything that HHS can be doing that would help along this line?
Senator Grassley, I appreciate the question. Before answering your question, I do have a couple of points. One is I want to be clear that pharmacy deserts occur not only in rural areas but also urban areas, negatively affecting the care of our most vulnerable patients. The second point is that community pharmacy is much more than just a place where prescriptions are filled. It's a place where patients have access to a trusted healthcare partner. It's a place where patients receive healthcare services ranging from medication management, point-of-care testing and immunizations to health promotion and chronic disease management. It's a place where care coordination and medication management service help patients achieve optimal outcomes. And it's a place where pharmacists and their staff work closely and collaboratively with physicians, other providers, and community-based organizations to optimize patient care. To answer the question, as far as the first part of your question and legislation, I think a good place to start is your bill S-526, the PBM Transparency Act, where it bans PBM deceptive and unfair pricing schemes, prohibits PBM clawbacks of payments that have been made to pharmacies, and improves transparency about spread pricing and pharmacy fees. Next, I'd like to address the fair reimbursement to community pharmacies and Medicare Part D. Senate Bill 5, or S-882, the Patients Before Middlemen Act, and enhances the PBM transparency and accountability to reduce prescription costs for seniors. Also ensures all treatments are fair treatment for all pharmacies as it relates to Medicare Part D contracts. But what's missing is, again, addressing reasonable and relevant Part D reimbursement from CMS to make pharmacies whole. Lastly, I talked about the services that we provide beyond prescription dispensing. I do think we have to develop some kind of a payment model for those services that is having impact not only on patient clinical outcomes, but also on total cost of care. Your second part of your question is about HHS and what they could do. And is it possible to provide authority for the Secretary of HHS to fix Medicare Part D payments for community pharmacies to ensure fair and reasonable reimbursement so we can continue to provide care to our senior patients?
Thank you. Ms. Faust, my PBM Transparency Act will require PBMs to be fully transparent about how much money they make and prove their value. What kind of transparency does Navitas provide to its clients, and what does real transparency look like?
Thank you. Navitas provides full transparency. We provide access to all the data, all the clients' data, and access to what pharmacies are paid and auditability of that as a fiduciary representative for our plan sponsors. I think your bill does a great job of introducing transparency, and that's really, really needed in this industry.
Okay. Next, I have a question for Professor Sode. The primary responsibility of a fiduciary is to run a health plan solely in the interest of participants and beneficiaries for the exclusive purpose of providing benefits. At least 5 states have imposed fiduciary or duty of care requirements on PBMs. I think you said this in your statement. Do you want to expand on what you said in your statement about the fiduciary responsibilities?
Sure. Thank you for the question, Senator Grassley. I think the price transparency bill that you have proposed complements fiduciary responsibility. So the idea of price transparency is to figure out if you're getting good value for your money or not, if your PBM is acting in the interest of your members or not. And what fiduciary responsibility does is it legally obligates the PBM to act in the interest of the members. So if you find out that the PBM is not acting in the interest of your members, you have some recourse to address that issue. So I think fiduciary responsibility combined with transparency can really make the markets work better for the American patient.
Okay. Senator Durbin.
Thanks, Mr. Chairman. I may be mistaken. I may have missed this completely as I listened to the witnesses. But I suspect that we have a federal issue that has been disclosed to us this morning at this hearing. I suspect that our witnesses have given us a challenge as to whether we're going to do something about it. I suspect there is a possibility that we may even have to legislate, pass a bill, make a law. And I think you've spelled out in graphic terms why this is essential. My challenge to colleagues on my side of the aisle and the other side of the aisle is, let's not walk away from this hearing and say, oh my God, that's really a mess. Let's do something that we were elected to do and legislate. The chairman has some legislation. I'm co-sponsoring some of it with him. Each of us has an idea, I'm sure, because we wouldn't run for office if we didn't. And we have a challenge that's given to us by this panel. Dr. Kircher, I tried to imagine you're walking into that patient's room day after day after day and explaining that the therapy he needed to stop the cancer in his body was being held up because of a fight, a jurisdictional fight about how to get the drug to the hospital. How in the world do you possibly explain that to your patient?
It's interesting because, as an oncologist, we're very well trained to deliver bad news. I can tell patients that they have a cancer, that it's progressed, that maybe they ultimately need to be transitioned to hospice care even. But what I've noticed since I started practicing in 2011 is increasing conversations that I am not prepared for. It's interesting that I can have a conversation about end of life, but I'm having more and more about affording our medications and making these difficult decisions that are well beyond the four walls of our clinic and involved just obtaining their medications. So as fast as we're hustling in clinic to see patients and get them what they need, we hit this roadblock that is really difficult to deal with.
So to my colleagues, what if this was a member of your family? What if it was your spouse or your child that we were talking about? I mean, that really brings it home. And Dr. McDonough, what you and Dr. Kircher told us about your belief in your professional responsibility to the patient really rings true to me. You care. And because you care, that patient's going to get better treatment. And the bottom line, Professor Sood, is you've gone through and analyzed these from an economics viewpoint. I'm really impressed with what you found. And Mr. Scott, the bottom line is this. You argue that PBMs give us competition, choice, and flexibility, and the evidence is absolutely to the contrary. What you've just heard, the illustrations on both sides of you, are proof positive that that is not your goal. I could go into vertical integration, the opioid crisis, spell out what PBMs have done over and over again. But how in the hell do you answer this Dr. Kircher's plea to us to give her patient the medicine he needs to get well and get into a battle over pricing? I mean, you say, well, you go into it voluntarily, you pick a PBM voluntarily. Clearly that's not exactly the case. Voluntarily, she had a pharmacy in her hospital that she wanted to use, but you didn't give her that choice. I don't see how PBMs, in the examples that we've heard today, have done the right thing for the patient. They've done the right thing for their bottom line. Please.
Ma'am, Mr. Durbin, thank you for the opportunity to comment on some of the issues that have been raised. And I want to start first by just expressing my sympathy for the experience that Dr. Kirchner shared. My father also suffered from cancer at the end of his life and then Alzheimer's disease. And the coverage that he had through his healthcare benefit, the way that that system worked in both instances to make sure that he was getting the drugs he needs. And you know about Alzheimer's disease, that requires constant changes and dosage adjustments. The way that that worked properly allowed my mom and I to spend time focusing on him at the end of his life instead of having to focus on some of those administrative challenges. And that is the way we believe the system should work for all patients. We want to make sure that is working better. As has been said before, those steps can be important in order to make sure that we are getting the right medicine to the right patient at the right cost. And at the same time, in today, 2025, the way that the system, we should not be using fax machines, right? We should be at a place where that exchange with the physician can happen in a more instantaneous place so that we don't have those unnecessary delays, especially in the case of pharmaceuticals like cancer treatment.
Mr. Chairman, to you and to my colleagues, if this isn't a call to action, I don't know what is. Imagine your own member of a family that you love going through this mess because we failed to change the law. I hope we do.
Senator Lee.
Thank you very much, Mr. Chairman. Thanks to all of you. Mr. McDonough, I'd like to start with you. With PBMs controlling formulary design and drug access, what prevents PBMs from steering patients toward their own pharmacies, even if cheaper alternatives exist?
It doesn't, I mean, that's one of the issues that's happening is that patients are being steered to, a lot of times to the mail order or to the brick and mortar pharmacies that they own. And so we don't even have that choice. And what's also concerning to me is the confusion that they bring into the marketplace, especially for our older patients who receive letters. They're not sure if they're supposed to go mail order. They don't know they have a choice. And they feel like if they don't do it, they're going to lose their benefit. And so they feel like they are being forced to do that. We see all kinds of letters that come to the patients that come to us to indicate that just adds to the confusion.
I can imagine this has the potential at least to harm independent competitors and to force consumers to pay higher prices. Have you seen that?
Absolutely, absolutely.
Now, Mr. Scott, in the negotiation with drug manufacturers, scale appears to be really important to PBMs, and one can understand why it could be. Now, the top 3 PBMs are vertically integrated, and they control, as I understand it, about 80% of the market. So in light of that, how do smaller PBMs compete without the scale and the vertical integration that the big 3 who control 80% of the market have?
Yeah, I'll try to be quick. I went too long for Mr. Durbin's question. Just real quick to address your steering question. PBMs and their design networks, when an employer hires them, just like you have a network of doctors and hospitals, a network of pharmacies, and they're looking at 3 considerations. When it comes to retail, geography, and then quality for the patient and cost. And whether it's an affiliated pharmacy or not, those are the considerations in designing the network. And the data would tell us that there are not higher reimbursements for affiliated pharmacies than unaffiliated pharmacies. If there were, and it was costing the employer more money, then the employer would not use that PBM anymore. On your point about integration in the marketplace and scale, yes, scale matters. Being able to use group purchasing economics to achieve discounts from drug companies. That's an important piece of what PBMs do. Smaller PBMs, in addition to trying to provide discounts, can offer a more tailored, unique level of service, benefit, patient experience, other considerations that an employer may have in mind when choosing who they want to partner with. So it really gives some optionality in the market, and the smaller PBMs compete by doing things in a different way than some of the established companies.
Okay, so you're insisting they can compete, notwithstanding that. Now, Professor Sood.
So I just wanted to tell you guys what a PBM is, because even though I've been in the insurance industry for about a decade, I wasn't like 100% sure. So this is ChatGPT's definition. A PBM stands for a pharmacy benefit manager. It's a third-party company that manages prescription drug benefits on behalf of health insurers, Medicare Part D drug plans, large employers, and other payers.
If I'm a health plan and I'm competing with you.
What they're supposed to do is they negotiate prices, they create formularies. So what a formulary is, that is, basically the list of drugs that the pharmacy benefit manager deems, what they can negotiate, what they think is important. It's kind of arbitrary in my opinion, but I'm probably wrong about that, and we can deep dive that a little bit later. But, basically they create a formulary which determines what drugs are going to be, covered and also what tier the drug is. And that's important because the tier of the drug is going to determine what the consumer pays. PBMs also process claims. So I was explaining this to my husband earlier. So you have an insurance plan. Let's say you have Cigna PPO. So Cigna is your primary insurance, but then you have this secondary PBM that administers the drug portion. So they're going to handle just the drug claims, whereas Cigna is going to handle the health claims. And then they contract with pharmacies. So, you're going to have certain pharmacies that you can go to and you're going to pay less because they're those contracted in-network pharmacies. And then they also manage utilization. So, if you ever needed like a prior authorization, like let's say you're on like a controlled substance, you may need a prior authorization. Things called step therapy, the quantity limits on controlled medication. So they manage that. So, this hearing is happening today because PBMs are actually very controversial. One, typically they lack transparencies. They allegedly keep a portion of the rebates they negotiate instead of passing those rebates on to the consumers. They also influence drug access. So their formulary decisions can limit what drugs patients can access or make some more expensive than others. And then also it has a big effect on pharmacies, especially independent pharmacies. Independent pharmacies often argue that PBMs reimburse them way below the actual cost, and they enforce unfair contractual terms. And unfortunately, especially for some smaller independent pharmacies, those PBMs have a lot of control and they can make or break a business. But we'll talk about that a little bit more. Let's get back to the stream.
Is responding to how sick Americans are of pharma pricing by proposing his executive order to lower it and set U.S. pharmaceutical pricing at international standards. I think that's a signal of how things are going out there. In that environment, a PBM done right is the only institutionally powerful correction to pharma's hegemony over prices. Now, we got a little bit of help by letting Medicare do some negotiation. That's a start. We hope we can do more of that. But other than that, it's just an open field advantage for Big Pharma to roll over individual patients with no structural opposition. So a PBM done right is actually a counterforce to pharma's, should we say, exotic pricing structures. Because they're able to buy at scale, because they can apply leverage, because there is excess profit baked into the pharma pricing model, they actually can provide a pretty important service. I don't know about you, but when I turn on my iPad, I pretty much always now see an ad paid for by pharma trying to throw PBMs under the bus for pharma's pricing policies. Now, if you're Big Pharma and people are mad about the way you price your drugs and why Americans have to pay more than essentially any other country for pharmaceutical costs, then as President Trump noticed by announcing this next executive order, there's a pretty fed up public out there. And pharma's response is not to lower its prices, but to move PBMs in the line of fire and try to make them the source of the blame.
I mean, they're both to blame. It's not just one party. I mean, Big Pharma's not great, but...
To point the finger at PBMs. There are clearly problems with PBMs, and the worst problem is if the PBMs and Big Pharma are colluding. If the PBMs and pharma are colluding to make the
I got a director, Dave the lawyer, in the background directing me.
And not complain about the basic pharmaceutical prices, so that they have a bigger margin that they can negotiate for their clients, so that they can get a bigger fee.
Is anybody else like kind of tired of senators talking about corporate greed or greed in general? Politicians talking about greed and things that are unfair. Like, it's kind of a joke. It really is. I mean, there's a lot of things wrong with our country, but
But the idea
There's a
that we
lot
need
of
to
things
get rid of
wrong
PBMs
with our
when
elected
they're the
officials and our
only
governments.
significant structural pushback on pharma's pricing, I think would be a real mistake. And when I'm seeing Big Pharma, knowing that everybody's mad at them, running all these ads, throwing PBMs in the way of public irritation, as if pharma doesn't control its own pricing. I worry about this. Mr. Scott, who sets the prices for pharmaceutical products?
Drug companies and drug companies alone.
Yeah, and you'd agree with me that if drug companies and PBMs are colluding to keep prices high just to give PBMs a bigger share and kind of a general truce so that consumers still get screwed, that would be an abuse of the PBM model.
And that is not happening, and you're pointing to the advertisements as good evidence there is no general truce. We have been calling actively for drug companies to lower their list prices on all prescription drugs. That's a key part of what we advocate for.
Yep. Well, my time has expired, but I think there's a role for PBMs here, and I think the most important signal we're seeing right now is pharma's ad campaign trying to defend its exotic pricing techniques by putting somebody else in the line of political fire.
Senator Whitehouse, you raised a lot of questions. The 4 bills that were in the last Congress, 1 in the House, 3 in the Senate, none of them did away with PBMs.
I mean, I think it's
but they
very
all called
rich
for
that
transparency.
everybody just wants to blame another party. I think it's really clear that
Solve at least part
all
it
of
by
these
transparency.
parties contribute to the problem. It's not just one thing. And it would be really naive for any of us to believe and point the finger at one thing. Because
In order to get the correct solutions, and I thank you for that.
everybody wants a piece of this pie. And it seems like nobody really just cares about the important person in this equation, which is the patient that needs these life-saving drugs. And a lot of these drugs are life-saving, not just talking about cancer drugs, but for some people taking hormone replacement therapy or antidepressants or even, mental health medication. It's life-saving, and it's not fair that everybody has their hands in the cookie jar and they're profiting off of our health.
Because pharma took a haircut. Nobody's talking about how wonderful it was that we had a 60% reduction in small molecule research, which we all know is one of the most promising fields for therapies and cures going forward. So you got to understand the consequences. If some of these companies were so flush with cash and we're not and can manage the risk, why on earth are they publicly saying in board meetings that they have a 60% reduction collectively in small molecule research? Just one point. I actually think everybody needs to get into the barber shop. I've been saying this for years. A haircut should be coming, but everybody has to be in the barber shop. The question is, are we going to end up with a haircut like Mike Lee's or one like John Kennedy's? And no offense, Mike, I like your new haircut.
It's a compliment.
But I know it. But the point is we keep talking past each other. I can't even get TRICARE, the biggest PBM for federal employees, one that I'm on. I can't even get transparency from them. I tried it in the prior administration. I want to audit the TRICARE PBM. At least we can eat our own dog food, right? And audit our PBM, but what I get back in response to a request on pricing information is a heavily redacted report. This administration, I'm going to try again. I tried it with the Biden administration. Can we at least audit our own PBM and in a confidential way figure out what's in the black box? And I think if we start doing that systematically,
every PBM should be audited. It has to do with our health.
Specifically into PBMs are probably correct. We're probably going to find out. I believe that for one thing we have to recognize is the PBM mission has varied dramatically since it was first established.
Ooh, you guys see our boyfriend Josh Hawley sat down, getting ready to speak. I know Watchdogs is very excited to hear Josh Hawley. We're all excited to hear him speak and what he has to say about this.
Versus using this forum to demonize a link in the value chain, then we're going to end up with the same old hearing that I've been to for the better part of 10 years now. We do it every year. It's great. Love it. We hear some very insightful comments, and we get nothing done. So I do think that today, and I have to respectfully disagree with the president, well, in the same way that I've criticized my colleagues and the former President Biden for a 60% reduction in small molecule research, for using march-in rights, trip waivers, everything else to solve this problem, I think they're wrong-minded. What is right-minded is to modernize PBMs, figure out what their value added is, determine how we implement
I kind of
price
agree with him.
transparency, and then
Not gonna
we
lie.
will create something that has an enduring value for the only person I care about, and that's the patient.
That's what I just
So
said.
I do have a quick question for you, Mr. Scott. What's wrong with the Professor Sood's suggestion that PBM should operate as a fiduciary?
Just on a basic level, the definition essentially of a fiduciary is a person or entity who is in a position of control and decision-making authority over another person's property or finances. The role of the PBM when hired by the employer or others is to recommend and to administer benefits at their direction. They don't make decisions for plan sponsors. They don't have that decision-making authority.
Then what else would need to change to make it reasonable?
Well, I think what a number of you have been pushing at around transparency is an important thing to comment on, because we have leaned in as an industry to try and engage with the committee, both sides of the Congress, on embracing transparency. If Congress says you want to set a floor, then we'll work with you to set that floor, as long as our clients can choose additional add-ons to that in terms of data and
Thank you.
reporting.
Mr. Scott, I hate to break you off, but Sir Grassley, I really think that one of the things that we should probably do outside of the structure of a committee is to have a work group for those of us who are willing to participate. Get all the players at the table so that we could have a good old-fashioned debate club versus the very limited question and answer that we have here. And that would be something, if you're okay with, I'd like to follow your lead. If not, then I'm likely to convene it myself so that I can get everybody in the room and we can have a very transparent discussion and comprehensive discussion about how we fix the value chain and how we ultimately address this problem. The most favored nation coming out of the administration, all these other things are short-sighted, unsustainable measures that are not going to produce the result I do believe all of us on this committee want to achieve. It's not the what, but we've got a very wide range of differences on the how. Thank you, Mr. Chair.
And health, and I think we'd have to get those chairmen to agree to that.
Yeah, I do agree with what he said, surprisingly. But really, the patient should be the number one concern, and it's really disgraceful that that just is not the case right now. Hopefully this hearing will produce results, but honestly, I find that most of these hearings are just political theater.
Over $24 million in unnecessary prescription drug payments, largely due to the practices that have been the focus of this hearing. And as a state, we have now enacted a series of PBM reform laws, notably all passed unanimously through our state legislature. I don't think that happens very often in any state. So I'm glad that PBM reform has some level of bipartisan support in Congress, including bills led by Chairman Grassley and other members of this committee. In fact, a ban on so-called spread pricing was one of the only provisions that I was glad to see in the House Republicans' reconciliation bill. Of course, I would have chosen to use the $1 billion in savings to fund community health centers and combat the opioid epidemic, not to give bigger tax cuts. But I'm glad for the opportunity to discuss what reforms could bring transparency, lower drug prices, and improve patient access. If I could, Dr. Kirshner, thank you for your work on pancreatic cancer disease that's impacted my family specifically. I've received substantial outreach from Delawareans about the need for PBM reform, from clergy to breast cancer survivors. How do PBM practices make it harder for patients struggling with cancer treatment to access life-saving medications?
There's a couple different ways, and the patients don't know that a PBM's even involved.
Right.
But where the rubber hits the road for them is like the disconnect between my prescription pad and them receiving the drug. Like some black box happens sometimes when we can't fill it at our specialty pharmacies, and that might be different within different specialties. So these are for highly complex chemotherapy drugs. And so patients, when we can't use our own pharmacy, really negatively are impacted.
I've seen that directly, personally, with 3 family members who've died of cancer. But thank you for your work and for raising that
They
issue
probably
today.
died from the cancer
If I
drugs.
could, to Mr. Scott and
Just
Dr.
saying.
McDonough, I've seen reports as high as 80% of rural and independent pharmacies receive reimbursement below the cost of procuring and dispensing some drugs. The owner of an independent pharmacy in Southern Delaware told me he can no longer even afford to stock certain expensive treatments for HIV, GLP-1s. His reimbursements after PBM fees are unpredictable, and he can't afford to lose money every time he dispenses one of these. Mr. Scott, why isn't there greater transparency into the reimbursement process? And Dr. McDonough, how could greater transparency help level the playing field, particularly for independent pharmacies and rural pharmacies?
I'll go first and briefly to say, understand the mechanics of how this works, because there is transparency when the pharmacy is choosing to contract to be part of a PBM's recommended network.
Right.
And more than 85% of those independent pharmacies are actually empowering a wholesaler through their PSAO, Pharmacy Services Administrative Organization, to negotiate on their behalf. You have 3 big wholesalers controlling 90% of the market. They're selling the drugs to the pharmacy, and they're negotiating these contracts on their behalf. And that is the starting point for determining how the reimbursement is going to flow to a pharmacy in a network.
I think transparency is key. You know, when you think about the physician writing the prescription and then the end user being the patient and normally filled at a pharmacy, there's a lot of stuff that happens in between.
Right.
And where things are getting siphoned off and everything else and fees. And I think, one, spread pricing we know is real. We, as an independent pharmacy, we had a local employer who approached us and asked us if we would be willing to do direct contracting with them. I was lucky that this CEO had experience in the insurance agency area, and he said that, I want to see if you give us a direct price, what that would do. That's been 5 years ago. They stay with us. They've saved a heck of a lot of money. Patients are happy because they get to go to a pharmacy that's going to provide services for them, and we actually made some money where we could stay open. So I do think transparency all along the line to find out what's going on. But I also think when we talk about rebates, that's so opaque. What do we have to do to really understand about rebates, and do we need rebates? I mean, that's a broad and a radical thing of thinking about, but let's just start from the very scratch and saying, can we do something where we know our actual cost? I couldn't tell you what my actual cost is because of rebates. So I do think we have to have a lot more transparency.
Ms. Faust, Dr. Faust, to follow up on the point that Dr. McDonough just made, should all PBMs be required to operate with the same level of transparency as yours when it comes to selecting drugs and obtaining rebates? And what other practices could PBMs learn from your company?
Yeah, we believe wholeheartedly in transparency and passing through rebates, especially as it relates to passing that savings through to the client. All PBMs should have transparency across the entire drug supply chain, and so that would be a great first step around rebates.
Thank you to all the witnesses today. Thank you, Chairman.
Thank you, Senator Cohen. Senator Kennedy.
Professor Sood, as I understand it, 80% of the PBM market is controlled by 3 companies, 3 PBMs that are vertically integrated. Is that right?
That is correct.
Does your research show that the prices that consumers pay are higher than they would be if those companies were not vertically integrated?
So my research on Medicare Part D...
Give me an answer.
Partially.
What do you mean partially? They're either higher or they're lower. There's no such thing as a partial price.
What I find is that Medicare Part D premiums are higher as a result of vertical integration.
Okay. Well, then why don't we, I'm all for transparency, Mr. Chairman, I want to say that. But why don't we skip the foreplay and go right to the sex and outlaw vertical integration for Part D? would you accept an amendment to your bill like that?
I don't want to answer that question right now because I want to study that.
Would you support that, Mr. Scott? Let me just guess what your answer is.
No, sir, and I can explain why.
No, you speak Sanskrit. I mean, I'm sorry. You know, you're good at it, and I know your job is to protect PBMs. And I might tell us, I don't think PBMs are the only ones at fault, but you don't have unclean hands. Professor Sood, you say PBMs ought to be fiduciaries. To whom?
To both the plan and their members.
Well, what if the plan and the members' interests diverge? Who are they fiduciaries to?
Ultimately, in principle, they should be fiduciaries to the members.
Okay.
So, for example, ERISA makes...
I get it.
Okay.
I get it. Mr. Chairman, again, why don't we skip the foreplay and go right to the sex? Why don't we just amend your bill to require that PBMs have a fiduciary obligation to plan members?
Well, I think that's been suggested, and I think there's part of that in our legislation, but probably not fully enough to satisfy you.
Well,
So let me look at what you want to add to it.
okay. I mean, I'm not criticizing your bill. I don't want my office to end up in Bethesda. I'm not criticizing your bill. I like transparency. But we're just nibbling around the edges here. And with respect, Mr. Scott, your definition of a fiduciary is wrong. Fiduciary isn't somebody that controls the decision. You know that, and I know that. Fiduciary is somebody who has a legal obligation to give his client the best advice and to do what's best for his client. It doesn't replace agent with principal or vice versa. You know that, and I know that. Well, you need to talk to your lawyers. I may be wrong, but I doubt it. Let me go back to Professor Sood. Tell me two things you would do tomorrow to fix PBMs and result in lower prices for consumers.
So I think the two things I would do is...
Very specific.
Yes. I would implement price transparency so that everyone knows what they're paying. And
Okay, price transparency just tells us who's screwing whom.
Yeah.
Okay.
And then the fiduciary responsibility says, if you're getting screwed, I can take you to court. So I would do those two things. And those are, I think, better than banning particular practices, because otherwise it's whack-a-mole. You ban spread pricing and something else will show up a year from now.
I got 29 seconds. Do you have any other suggestions? I appreciate your
So
straight talk.
the other thing we can do is, what I recommended is pass-through of rebates to patients. So suppose a drug...
Say that again?
So pass-through of rebates to patients.
Uh-huh.
So for example, the list price of a drug is $50,000, but the rebate on the drug is $40,000. So when a patient is paying cost sharing, suppose 10%, they should be paying on the post-rebate price, so which is the $50,000 less the $40,000 rebate. Right now, what's happening is patients are paying cost sharing on the $50,000. So this would immediately lower patient out-of-pocket costs. So as Dr. Kircher said, for the cancer patients.
So you're saying the number after us, the PBMs are jacking up, are encouraging manufacturers to jack up the list price so they can jack up their rebates.
And that
is that right?
Yes.
That's illegal.
And the jacked up.
That's illegal.
Yes.
Wow.
I don't know about that, but
Wow.
I do.
Okay.
It's illegal as hell.
Yeah.
Before I call on Senator Ronald, I want to remind my members we got a vote and they're enforcing the 30-minute rule. So I'm going to go vote. Will you take over while I'm gone? And then
So I just want you guys to understand what they're talking about when they say, there's 3 PBMs that really control the market.
Prescription drug supply chain.
So, those 3 PBMs also are owned by major healthcare company. And those three PBMs are CVS Caremark, Express Scripts, which is owned by Cigna. And just so you know, CVS Caremark also owns Aetna and CVS Pharmacy. So they're the pharmacy and they're the pharmacy benefit manager. No conflict of interest there. Express Scripts, owned by Cigna. And the third one is Optum Rx, which is owned by United. And this owns up to 80% of the market. This is an issue because it basically creates like a monopoly. And, the problem is that these pharmacy benefit managers are determining what medications are going to be put on the list, what medications are covered by insurance. And this is so beneficial for an insurance company because they could be like, oh, okay, I don't want to, cover this life-saving drug because it's expensive and I'm not getting a great rebate. So it's not going to be on our formulary, or it's going to be, a tier 5 or 6 specialty. And if the customer needs it, they're just going to have to pay for it. But the problem is these pricing is so inflated. And then the other thing to think about also, so CVS Caremark is the PBM. The health insurance company is Aetna, and the pharmacy is CVS. They're all owned by the same company. They're all in bed together. It's an issue. Optum, I've heard from independent pharmacies and doctors, they're like the worst. They have these arbitrary rules, and they go into these independent pharmacies and they do audits, and they actually claw back, tens to hundreds of thousands worth of payments if you don't follow all their arbitrary rules. And I know this to be true because I know pharmacies that this has happened to. But let's not forget the CEO of United Healthcare, that Optum is owned by United Healthcare, was gunned down for a reason. And I think we've all kind of forgotten what that reason is. People are so, free Luigi or whatever. But there was a lot of stuff going on behind the scenes with Optum and United. And that really just got kind of like shoved under the rug. But there's more to that. We'll continue on this. But I wanted you guys to understand the impact of having 3 PBMs that also are owned by pharmacies and insurance companies. It's an issue for everybody, especially the patients.
That a certain entity such as, I would say, the Iowa AGs said that the spread pricing enabled PBMs to retain millions and millions in probably undue profits. So what do you say about eliminating spread pricing? There are some states that have done that, including Hawaii.
We support transparency, and that includes transparency to what pharmacies are being paid, which is why our model aligns with clients paying what pharmacies are paid and no spread or capture in the middle. That supports both pharmacies and the plans, which should really be the gold standard to support patient care.
The other thing I want to add, just for everybody out there, and really take a look at what you're paying, especially for generics. What I found over the last few years is that it's actually cheaper to use discount plans like GoodRx, or even just paying cash for certain generic drugs. Some of the plans out there, Optum especially, in the under 65 market, you look at the formulary and the price for generics, and some of that pricing is a $35 copay for a 30-day supply of a generic drug, where, a lot of these generic drugs are like under $5, $10 if you just paid cash or used GoodRx.
So what is the kind of reform that we need to do with prior approval by PBMs?
Yeah, and I think a good point has been made by a lot of people in this committee of that it's probably not just the PBMs. I think there's every line in the chain, coming from the manufacturers, the payer, payer solutions, as well as we saw with the Inflation Act and insulin. But I mean, I think we need to, I got lost in the question. What was the question again?
Prior approval. What can we do to reform
approvals.
prior approval?
No, I think these drugs are so expensive that we get it, that you need prior approval. We just need them resolved quickly and effortlessly. You know, I think that's the main thing that we're asking. Not that they don't exist, but that we can resolve them quickly.
I think that is a hard road to go, considering PBMs don't really have the expertise, from my understanding, of making these determinations quickly. Thank you, Mr. Chairman.
Thank you very much, Senator. Mr. Scott, let me start with you. You represent the largest association of PBM companies, I think. Is that right?
Yes, sir. I believe the only.
The largest and only. Perfect. Now, just help me understand what it is your business is supposed to be doing. You're supposed to be making drugs cheaper for patients. Is that basically right?
We're supposed to help employers and plan sponsors administer benefits at a more affordable point for the consumers.
Okay, more affordable for consumers. That's patients. So you're supposed to be making would you say that you're succeeding?
We've had success in managing the net cost of drugs across most categories of medications, and yes, in large part, but we have the challenge of ever escalating drug company list prices to work against.
Okay, let me translate that for you. I think the answer you're looking for is no. You're not succeeding at all. Look, let's look at some data. This data shows the percentage that Americans pay more than other countries for brand name drugs. In Canada, we pay 324% more than Canadians pay, 445% more than France, and so on. On average, all together, we pay 422% more than all of these other countries. Now, either you're the worst negotiators in the history of the world, or something's wrong with your business model. Which is it?
Those, if I may, Senator, those are comparisons of list prices. Drug companies alone, as we talked about earlier, set the list price. The PBM is negotiating down the net cost.
Look, this consumers are. You're not telling me that consumers aren't paying more in the United States than they are overseas, are you?
I think the data would tell us that they are exposed to higher price points. And then it comes to an issue of benefit design. The plan decides what your copay
is. And the benefit, here's the benefit design. The design of the plan benefits the insurance companies and you. It does not benefit the patients. Patients are getting screwed, if I may. We are paying 2, 3, 4 times more for drugs. People in my state can't afford insulin. They can't afford the most basic drugs. That's when they have plans that are managed by you. And you guys are getting rich off of it. I mean, absolutely filthy rich. The FTC's report, so this is the government report now, found that the top 3 PBM companies generated $7.3 billion in profits between 2017 and 2022. $7.3 billion. That's a lot of money. Why is it that nobody can afford their drugs in this country, but you're making $7.3 billion? That's more than the revenue of some nations.
If I may, 2 points. One, you're not wrong that we need more competition among drug companies. The patent reforms that you all have advanced in this committee, the more we can have competition, we can leverage that to address that cost challenge that we have.
I'm glad you say we need competition,
and
because
second,
don't you think the competition we really need is to break up this alliance between insurance companies and PBMs?
No, sir.
The biggest 3 PBMs are owned by the biggest insurance companies. You're like one huge, giant pharma industry, a giant pharma series of monopolists, right? Why is it a good idea for the biggest PBMs to be owned by the biggest insurers, and now you're buying up pharmacies as well? Why should we allow that? Why should insurance companies, PBMs, also own pharmacies?
So a couple of...
How is that good for patients?
It's good for patients and for plans because it's creating optionality in the market.
It's creating optionality. In the state of Missouri, just last year, we lost 73 independent pharmacies across my state in 19 different counties. Do you know that 2 entire counties in the state of Missouri now have, wait for it, 0 pharmacies? 0. Now, you are making $7.3 billion, you and the companies that you represent, and yet 2 whole counties in the state of Missouri have no pharmacies, 73 closed last year. Why shouldn't we be breaking you guys up? I mean, this looks like classic monopolist behavior. The patients are getting screwed, Missourians are getting screwed, you're getting rich.
Respectfully, Senator, you keep citing a gross revenue number. of the drug, every dollar spent on prescription
You're not making,
drugs.
you don't have profits?
Profits are in the low single digits on
Your
average
profits
for
are
our
not
industry.
better than they've ever been?
I don't know on the trend over the years.
Yes, you
but
do.
it-
You
it
know
was a
exactly.
low-
It
the
is all
lows-
laid out in the FTC report. You absolutely know the answer. Your profits have increased and increased and increased, and now you are buying up pharmacies, and you're buying up pharmacies and you're putting independent pharmacies out of business, and you're doing it deliberately because you are giving special rebates and lower costs to the pharmacies that you own, and you are directing patients to the pharmacies that you own, such that if they don't go to a pharmacy that you own, they have to pay higher costs, they have to pay out-of-network costs, right? You're nodding your head, Dr. McGonigal. You've lived this, right?
I have lived this. I live it every day. Yes, that's exactly what's happening.
So, Mr. Scott, why don't we break you guys up? Can you agree? I mean, if you believe in competition, you just said a second ago, we need more competition, by golly. Well, let's do it.
And
let's break up the PB. Let's pass a law that says PBMs cannot own pharmacies. You for that?
No, sir. And we've seen that competition grow in the last 5 years by 18% in the PBM market, by 9% in the last 2 years.
Wait a minute. You've seen the number of pharmacies grow in this country?
The number of PBMs, meaning it's a competitive marketplace.
It's not a
Independent
competitive
pharmacy
marketplace.
data-
The biggest 3 PBMs own 80% of the business. 80%. And you're in turn owned by the biggest insurance companies. The problem is there is no competition. It's a racket. It's a total racket. And the people who lose are the patients who cannot afford the prescription drugs. It's time for this Congress to do something about it. Now, Senator Welch, I recognize you.
Thank you very much, and I associate myself with the remarks from the senator from Missouri. We only have 126 independent pharmacies in Vermont. They've been going out of business left and right. My view, they're absolutely critical to the community. Main Street's getting devastated. This is especially true in rural America. And Jeff Hochberg, who's the head of our independent pharmacy group, he's got a pharmacy in Rutland and a few other places, showed me the DIR returns. And you have the same problem, Mr. McDonough, that I think all independent pharmacies have. You get paid less for filling a prescription, and you don't even know you're going to get a clawback from the PBM until after the fact. Is that true?
That is true, especially as we look, they're doing true-ups now, where from 2 years ago or something, because of our PSAO.
But it was thousands of dollars.
It is.
It's unbelievable.
Yeah.
And by the way, I just want to acknowledge, my first wife had cancer. The pharmacist was so crucial to us. You're getting cancer-related drugs, and you get the prescription. And Dr. Kirshner, you know this, and it isn't exactly the way it's trial and error as you go on. And the person we could talk to was our local pharmacist. And God bless you all for the work that you do for all of our communities. But Mr. Scott, I want to ask you, how in the world can a business survive if they sell the product at what is an agreed upon price, and then you reimburse them at a lower price months after the fact? How in the world is that a fair business model that makes it at all possible for our community pharmacies to survive?
Just two quick holding statements, and then to address your question.
I don't want two quick holding statements.
Well,
I have a simple question. They agree on a price, you agree on a price, and then you do a clawback.
And we all
This is
have the
some
same
complicated formula.
We all have the same goal, Senator. We need a healthy retail pharmacy market, because if we can't serve patients with those access points.
You know what? We don't have a healthy retail pharmacy market.
And we
it
have
doesn't
ideas.
exist. They're under incredible pressure, and we can be blind to it. But you're suggesting, I want an answer of how we deal with Mr. McDonough, and how we deal with Jeff Hochberg, and how we deal with all these community pharmacies in our small towns throughout the country. What's
Those
your answer?
reimbursements are per the agreed upon contract that the PSAO negotiates on behalf of the pharmacy. Now,
All right. I'm going to interrupt here. Professor Soon, you told me that 40% now of the cost of pharmaceutical drugs is in the supply chain, all right? So that's people reaching in who have access to this market, which, by the way, the individual consumers have no access to at all. They just got to get the drug for a person they love, and they'll mortgage their house, they'll sell a retirement, they'll do whatever it takes to take care of the well-being of the person they love. So this question of DIR and clawback, is that one of the aspects of how this is getting to be such a ripoff?
Yes, completely. And I agree that for a business if you don't know what the price you're getting for the services you provide. And I don't think it's a choice for independent pharmacies, because if the big three PBMs control 80% of the market, they control 80% of the patients. So if they don't sign a contract with the PBM, they lose 80% of the market. So I don't think there's a real choice here.
Thank you very much. You know, it's oftentimes not what you do, it's how you do it. Like, I think we need pharmaceutical companies to help us with drugs, but the pricing that they do is terrible. We may need PBMs, but how they do it makes a huge difference. Ms. Faust, I was impressed at the transparency in your PBM. And the information you provide, is it different than the information that the other PBMs provide?
Our practices are different. They focus on lowest net costs, and we've never actually done DIR practices.
You've never done that, so you've survived.
No, because we believe that that wasn't...
Okay, you're going to, I mean, it's clear what happens. We squeeze and crush the independent pharmacies. What about on the pricing? Do you share information with your members that is not shared with the people who sign up with Mr. Scott's organizations?
The pricing for the plan sponsors is auditable and available. Patients get pricing through any sort of applications, which are also a PBM standard.
Well, what's the transparency you have that is different than the transparency from the Mr. Scott organization?
We have all of our fees fully disclosed.
Are your fees fully disclosed?
Many of our members offer the same model.
What?
Many of our member companies, as an association, our member companies offer the same model.
Here's the question I asked. Are your fees disclosed? Could I look up your fees right now?
We're a trade association with a number of individual company members, and I'm saying those companies, many of them structure it the same way as Navitus.
All right, my time is up. Thank you all very much for your testimony. Senator, I'm sorry, you're the chair.
Yes, thank you very much, and I'll recognize myself for questions. I want to thank all of you for being here. This is an issue that our healthcare marketplace has struggled with for many years. And Dr. McDonough, I do want to come to you first, because in Tennessee, where I represent, since 2010, we have had 120 of our independent pharmacies close. And this is tragic. Many times that pharmacy is the only access point for health care in these communities. And to a pharmacy, when I go in and talk with these individuals, and I'm in each of our 95 counties every year, and they will talk about how horribly they were treated by the PBMs. So I'd like for you just to talk about, for just 30 seconds, about how growth and consolidation around this PBM model has strangled not only you, but other independent pharmacies.
You know, when we saw the chart that showed the $7.3 billion in profits that the PBM industry is making, I can guarantee you during that same time, from 2017 to 2022, we just saw our profits going down to the point where we have no profits. We're being squeezed. And that's very concerning to me, because when we lose that community pharmacy, whether it's in an urban area where they might be the community pharmacy for that area, or in a rural area that we're in, they aren't coming back. I've had so many mayors and city managers and towns come to me and saying, will you open up a pharmacy? I'm like, we can't. Yeah. We can't afford to. So it has had dramatic impact on us to the point where now we've closed a pharmacy and converted another one to a hybrid telepharmacy, and that's still struggling. And I want to make it clear, it's not because we're bad business people. I want to make that perfectly clear. It's because we are not making any money on the drug, let alone the services that we provide to the patient to ensure that patient is achieving a therapeutic outcome with that medication. So we're losing it twice. We're losing it on the drug side, and we're losing it on the service side. There's no way.
You're right about that. I want to talk about bad actors with Mr. Scott for a few moments. We recently had the Department of Commerce and Insurance in Tennessee
do a report that gave us some really disturbing information on one PBM in Tennessee. And what they found was that they were forcing these independent pharmacies, the non-affiliated, to pay a higher inflated rate on over 550 drugs. And they profited more than $30 million through spread pricing. Now, this gets to my first point about those 120 independent pharmacies that we have lost in Tennessee. Now, this same PBM failed to reimburse 265 pharmacy claims within the legally set 7-day business day period. And that impacted 40 separate pharmacies in the state. You know, it doesn't take a lot to connect the dots on this, and there are so many examples of these egregious practices. For the purpose of this hearing, I've given you one finding from this report. And what we have seen is, you talk about transparency, we don't have it. And it is insulting to patients and to pharmacies and pharmacists and to these independent pharmacies. So talk to me about how a $30 million spread and delayed reimbursement for pharmacy claims meets the transparency standards you claim the PBMs are putting in place.
Thank you, Senator Blackburn. I can't speak specifically to the individualized example, but I can cite to another report that was recently produced by Dr. Carlton from the University of Chicago, looking at these questions and using the exact same data set that's been submitted to the FTC for their ongoing study. And the conclusion was that unaffiliated pharmacies are not being paid less than affiliated pharmacies.
Well, I will tell you, in Tennessee, that is not the case. And if you would like to see the study, I would be more than happy to submit it to you.
I will certainly take a look at it, Senator. If I could make 2 quick points.
Very quickly, my time's expired.
The practice of affiliation is not unique. Hospitals, wholesalers, grocery stores, Amazon, others are all partnering with pharmacies in order to provide that efficiency of care. And the other is, this same point has been made a couple of times, paying pharmacists to be able to do more services for patients is something that we really strongly support, and there's legislation.
Do you support that like you support the hike in administrative fees that your pharmacies have put in place? They have doubled. Doubled? You've got administrative fees for prescriber education, medication adherence, data analytics, pardon me, and these have increased 51%, 3.8 to 5.7 billion in a 2-year period of time. If I had my way, I'd do away
Senator
with
Blumenthal.
PBMs.
Thanks, Mr. Chairman. Thank you all for being here, and thanks for holding this hearing. I want to come back to the rebates issue. We all know that pharmacy benefit managers negotiate with drug manufacturers on rebates, and theoretically they can save money for consumers if the PBMs pass along the benefit of those rebates to their clients, the employers and others, that then can use the money to reduce the plan's cost. There's been some debate, I know, and discrepancies on the issue. Last summer, the 3 largest PBMs testified in Congress that 95 to 98% of the rebates they collected from drug manufacturers go back to employers. Last year, the Kaiser Foundation conducted a survey, I think it's 2,142 randomly selected companies, and found that only 1 in 5 of those employers actually received most of the rebates. The other 4 and 5 didn't know what percentage of the rebate they receive or reported receiving. Only some or a little bit of the rebate. I know the PBMs have long argued that rebates help employers, by providing flexibility in their benefit designs and in other ways. But if the employers aren't getting most of the rebates or don't even know what they're getting, tell me how there's merit to the PBM's arguments. Mr. Scott, could you explain, I know there's been some discussion of it here, how you reconcile the argument that the benefits go to the employers when the employers aren't getting those benefits or don't know whether they're getting them?
Thank you for the question, Senator. I believe they are getting them, and they have the optionality to choose to get 100% of them or to use.
Well, you believe they're getting them, but the Kaiser Foundation found they're not.
I think the discrepancy we've seen in the data is that some of it is not reflective of the trend, that we have seen a lot more of that pass-through model in the last year to 18 months. And that's a pot that more employers are saying, we want them all. We've had one of the big three PBMs say, we're going to do only 100% rebate pass-through contracts.
You're saying the Kaiser Foundation survey is outdated?
I would need to look at it to understand. I'm making a supposition that that's maybe why it's not lined up with the other studies from GAO, from Dennis Carlton, from others.
What has changed in the last year?
Employers are making a different choice. They're using their ability to design their contract to say that they want 100% pass-through in more instances.
And you're saying that has made a radical difference in whether they're getting the benefits of rebates?
That choice has always existed.
Contrasted before when they weren't getting benefits.
That choice has always existed for them. And so we are for transparency to make sure employers are getting all the information when they're making that decision and then letting them choose whether they want to receive the rebates or use them differently.
What's the latest credible study that you would urge us to
The piece completed by Dr. Carlton from the University of Chicago, which was just updated in the last month, shows that we're almost at 100% pass-through rate.
I haven't seen that study. Has anyone else on the
We'd be happy to share that with you.
Thank you. None of you have seen it. Let me ask all of the witnesses on patent laws. You're all familiar with the drug manufacturers' misuse of patent laws in retaining, in effect, monopolistic control. Do all of you agree that reforms in the patent laws would enable lower costs for consumers?
Yes.
Yes.
Hopefully we'll have unanimity because my time is about to expire.
Yes.
I take it that we do. Thank you, Mr. Chairman.
Senator Britt.
Thank you, Mr. Chairman. Mr. McDonough, or Dr. McDonough, as an independent pharmacist operating in a community setting, you are not just a healthcare provider and part of that ecosystem, you're also running a small business. We've seen over 6,500 independent pharmacies close their doors since 2010. And in Alabama, we looked at the reliable data between 2015 and 2018. We had over 225 close their doors. That goes to a rate of about 1 per month. When you're dealing with a state like Alabama, when in our rural communities, local independent pharmacies is often the only healthcare provider within 20 or 30 miles, this is absolutely, completely unacceptable. When PBMs impose retroactive clawbacks, DIR fees, and below-cost reimbursement rates, they're not just squeezing your bottom line, they are pushing out entire communities towards pharmacy deserts. Based on what you've seen, are current PBM practices accelerating the loss of rural pharmacies? And what does that mean for basic access to medications and clinical services in places like rural Alabama?
Yeah, I would definitely say, excuse me, that it has been accelerating. If you look at just some of the past information that we've had within our own pharmacy and looking how much we lost, and I'll use the pharmacy that we just closed. 2 years ago, we were at a negative $95,000 as our net amount that we made. Last year was a negative $75,000. Then we dug into the data. 25% of all the prescription claims that we filled were lower than zero.
Unbelievable.
So it's negative. A third of the prescriptions were $0 to $5. What does that mean? Well, if we look at cost of dispensing, you talk about being a small business. I hire people. In my corporation, in our corporation, we have 70 to 80 employees. I take it very seriously, when we have to think about closing something because I'm affecting people's potential livelihoods. I've also seen how community pharmacies, when they close up, how the community misses them.
Absolutely.
Because they may be the only healthcare provider, as you said, that they have access to. And these are not just community pharmacies. These are people who are trusted within the community, who contribute back to the community. These are the people who get the calls after hours and actually will take a drug to a patient at their home. That's what's missing. And we're going to be losing more and more. So as long as we keep debating about this, because people have asked me, do you think we're going to see more closures? I'm like, absolutely.
There is a relationship aspect in our rural communities that cannot be matched. When you're looking at creating opportunity, that opportunity for the American dream, you can't draw in that opportunity without access to care, without access to pharmacies. No one is going to come and locate a plant and create good paying jobs or decide to expand in a place that has a pharmacy desert. We know that that is true. And so looking at this in a place like Alabama, where 55 out of 67 of our communities are rural communities, they deserve better. And so when we're looking at all of this, and I think Mr. Scott made clear this morning, most employers do rely on PBMs to manage cost. But still, as the PBM debate rolls on, I'm struck by how the patient and employers, the ones who are actually paying the bills, seem to be the least empowered voices in the entire system. Employer-sponsored health care insurance remains the primary source of health coverage in America. So more than 164 million Americans obtain coverage through an employer. Dr. Sood, why do most employers accept a model where intermediaries are incentivized by the size of the rebate rather than the value of the drug to the patient?
So I think the challenge is employers don't have a lot of choice. 80% of the market is controlled by the big three PBMs. And, that scale is important in leveraging discounts from manufacturers. But I think employers would prefer a model where there was a direct price reduction and no rebates, because then I can make sure that I've got the money, right?
So are those the structural reforms that you believe are needed, or what else do you think is needed for more visibility, bargaining power, and value for our dollar?
So I think what is needed is greater transparency so that we know, or employers can know whether they're getting a good deal or not. And we need a fiduciary responsibility for PBMs that if they don't act in the best interest of plan members or employees, we can address that in the courts.
And one final question. Dr. Kutcher, do you believe that rebate-driven formula design and utilization tools reflect sound clinical judgment?
Oftentimes, no. Oftentimes, we are trying to fight for medications that are nationally guideline accepted that we are still fighting for.
Thank you.
Me to stay here till the end of the meeting, but just in case something happens, I want to say to all the panelists, as chairman of this committee, thank you for your time and hard work put into this. Senator Booker.
Mr. McDonough, what happens when a person with a life-threatening disease cannot get access to a life-saving drug?
Not a good outcome.
Be more specific for me.
If it's a life-threatening situation and they're not getting access to that medication, then the life is at danger.
And you know situations, right?
I do know situations.
Where contributing to the death of an American was their inability to access, over time, the life-saving drugs that they need.
Or because of the process of being put into place, such as prior authorizations, that wasn't done timely and the person stroked and died, yes.
So why aren't we calling this what it is? My friends across the aisle and others have called this a scam. Multi-level marketing is a scam. Internet people that prey on senior citizens, that's scammers. This is a level of corporate violence that is costing American lives a level of colossal greed at the expense of patient well-being. Am I overstating the fact, Mr. McDonough?
No, there's situations like that with every pharmacy.
Yeah, and so I've been in your state, and I sat around a table of senior citizens who each of them told me stories that they ration their drugs against doctors' orders, cut pills in half. What kind of peril does that put people in?
They're not getting the medication they're supposed to be getting, and it's going to be endangering their lives.
Endangering their lives because the desperate people in our country who have drugs for cancers, have drugs for heart conditions, have drugs for conditions that are threatening their lives, are put in the moral dystopia of having to make a decision that is not left to them, to ration drugs or not have them at all when they fulfill the prescription, when they can't fulfill the prescription from their doctor. This is not a scam. This is a moral obscenity, and it's corporate violence. The former FTC chair, Lena Khan, under her leadership, released an interim staff report that found that the three biggest PBMs, Caremark RX, CVS, Express Scripts, and Optimum RX, marked up numerous life-saving drugs, thousands of percents, and many others by hundreds of percents, dispensed at their affiliated pharmacies. These drugs include treatment for cancer, HIV, multiple sclerosis, pulmonary hypertension, and more. Shockingly, hundreds of times the cost of people just over the Canadian border. They made more than $7.3 billion in revenue from dispensing drugs, hiking up prices over the course of just 6 years. This idea of breaking up big medicine is not just about dealing with awful antitrust. And there are a lot of industries where corporate concentration has caused consumers to pay more. But in this case, it's not just causing consumers to pay more, it is, as your testimony has said, threatening the lives of Americans. PBMs are not the only contributor to high drug prices, but the vertical integration that's allowed powerful market players to buy other entities in the supply chain and steer patients towards drugs with higher out-of-pocket costs is causing grievous harms in a country, and it cannot be allowed to go on. According to the research of the American Economic Liberties Project, released on March 10th, at least 326 U.S. pharmacies have closed just since December 19th, 2024, when Congress abandoned a bipartisan, bicameral PBM reform as part of the stopgap spending bill. We know how to solve this problem. Inaction is complicity. There is nothing short of an evil going on in our country that is allowing millions of Americans to suffer under an unjust system that's hurting small business people with you that have a larger focus in life. Not only running your business, but helping rural communities. Again, I've been in your community, helping people get access to drugs, even when you deliver them in the middle of the night. This is wrong. This is unjust. This is violence. This is moral obscenity going on in our nation. We know the solutions. This committee has got to fix that. Thank you.
Senator Schiff.
Thank you, Mr. Chairman. Thank you for holding this hearing, and thank you for the work you've done to try to reform the practices of PBMs. I have a long family history in this area. My grandfather was a pharmacist. My great-uncle turns 100 this week, was a pharmacist. My father worked in a pharmacy growing up. And of course, I've had the same experience that so many of my constituents have had. Dr. Sood, thank you for coming all the way from California. Let me ask you about my experience, because it's left me wondering what player in the scheme of things was responsible for my experience, which was minor compared to what others have experienced, and that is I was on a medication prescribed by my physician, which was working very well without side effect.
Senator Schiff, when you're done, will you adjourn the meeting for
Yes, I will.
Thank you very much.
And I may have to cut it short to get out in time to vote. So I was on medicine that was worked with no side effects. I got a letter, I think either from my insurer or PBM, saying we're taking you off that medicine and putting you on a different one. And I called my physician and I said, why are we changing? My medication was working perfectly. Well, probably someone is going to get paid more money by moving you to something else. And I said, well, is there an appeal? And he said, yeah, but you'll lose. And I said, well, let's appeal anyway. So we appealed, and he was right, I lost. And then I said, is there any other remedy? He says, well, you can appeal one more time, but you will lose again. We appealed one more time, I lost again. So who made the decision to, well, obviously it wasn't my physician, who made the decision that I was better off on a different medication?
It was the PBM, and I've had a similar experience where my university changed their PBM, and there's a generic medicine, FDA approved, been in the market for 30 years, well established, suddenly wasn't covered because of the change in PBM.
California experienced a 56% increase, its Department of Managed Health Care, in health plan spending on prescription drugs from 2017 to 2023. How much of that do you think is because of consolidation in the industry? Where would you apportion the increased costs?
So I was one of the experts who, back in 2017, opposed the CVS-Aetna merger on vertical grounds because I thought it would reduce competition in the pharmacy market, reduce competition in the insurance market, and lead to higher costs. I haven't seen the study, but I agree with the general hypothesis that vertical integration could be responsible for higher costs.
Well, I wish I had more time to ask questions, but I'm likely not to make it in time to vote without adjourning. Thank you all for your testimony today. This concludes our hearing. I want to thank each witness for taking the time to share your experience. Written questions can be submitted for the record until May 20th. I'll ask the witnesses to answer and return the questions.